All right. Hello, and thank you for joining us for today's virtual education program at Cancer Support Community Health South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Long-Term Complications After Treatment. Before we begin, if this is your first time joining us, CSC South Bay's mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community so that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join a community, please visit our website at cscsouthbay.org. Without further ado, to introduce our workshop speaker, Dr. Philip Chang is Assistant Professor in Cancer Rehabilitation Medicine at Oschin Comprehensive Cancer Center at Cedars-Sinai Medical Center. He completed his residency in Physical Medicine and Rehabilitation at SUNY Downstate, followed by fellowship in hospice and palliative care at Montefiore and a fellowship in cancer rehabilitation at the University of Michigan. Thank you so much, Dr. Chang, for being here with us today.
Thanks so much for inviting me, Rebecca. I just think I did see something in the chat that somebody said they had to re-register for the meeting, so I don't know if like another link needs to be set out just in case, but I'll go ahead and get started here. So I'm gonna try to share my screen here. And I think that should be showing. Can I get a thumbs up from anyone?
Yeah.
Perfect, thank you. Okay. All right, great. Just want to say thanks again to CSC South Bay for inviting me back to talk about basically long-term complications. Again, so I gave this talk last year, and there are some things that I've changed and updated, but there's kind of a new section that I also just added just regarding chronic post-surgical pain. So hopefully, you know, if anybody is kind of re-attending from last year, hopefully there'll be at least something new out of it. So anyways, again, the topic for today's session is going to be long-term complications following cancer treatment. And I don't have any disclosures. So the specific complications I'm going to be discussing, and of course, there are other complications besides these, but kind of the ones that I want to focus on today are radiation fibrosis, fatigue, peripheral neuropathy caused by chemotherapy, cancer-related cognitive impairment, more commonly known as chemobrain or chemofog, and again, this new kind of one that I added this year, which is chronic post-surgical pain. And you know, again, if there's anything missing from here that anybody wants to talk about, feel free to just throw it in the chat box, and we can definitely address it at the end. So getting right into it, the first complication is radiation fibrosis. So what is radiation fibrosis? This is essentially a hardening of the soft tissues in the area that somebody gets radiation treatment. And radiation fibrosis syndrome is basically all the manifestations and symptoms that occur because of that tissue hardening. So, you know, for example, a lot of people maybe head and neck cancer, they'll get radiation to their neck area, or people with breast cancer, they'll get radiation to their chest wall. And essentially what you'll see is, you know, kind of immediately while, you know, people are undergoing radiation, it'll be like kind of like a really bad sunburn. And then like months or years later, you can actually get a hardening of the tissue where like if you touch the tissue there, it'll feel different, it'll feel harder. If you try to press on it, it won't like indent as much because it'll just be more firm. So these are all kinds of symptoms and manifestations of radiation fibrosis. So why does this occur? So basically there's molecule in the body called thrombomodulin. And when you get radiation treatment, it kind of knocks out thrombomodulin, which is this TM right here. And I can see if I can get my little laser pointer up right here. And that essentially activates kind of this blood clotting cascade. And that cascade essentially causes these mesenchymal cells to basically increase and drop down more collagen into the tissue. So it's kind of an oversimplification, but essentially through radiation, you get fibrous tissue and collagen tissue that is deposited into the area of radiation. So kind of in your body, it would look like this. So, this is like your skin at the top, this is kind of the fatty tissue, and these are like your blood vessels, and this is like the lymphatic vessel, and then these are like your nerves, and then this, this area is like your muscle. So, when you undergo radiation, and then again, it knocks out thrombomodulin, and then you get kind of increase of that clotting cascade, which then results in cells depositing this kind of scar, fibrous fibrotic tissue into all these cells. There's a bunch of things that happen. So, it can kind of choke off the nerves, as well as like the blood vasculature and also lymphatic. So it could result in lymphedema because again, your lymphatics are being choked off. It could result in nerve problems because the nerves are being affected. And when the nerves are affected, the muscles can actually atrophy and shrink. And then again, it could also kind of affect the blood vessels and kind of narrow blood vessels. So there's a lot of different things that can happen. But one thing to keep in mind is that really to diagnose radiation fibrosis, the symptoms that you're having have to be in the area where you receive radiation. So if you got radiation to your chest wall, but you're having symptoms in your leg, it's probably not related. That's probably not radiation fibrosis. But one way in which it could be related, but not directly in the field, is if the nerve is directly in the field, but then because the nerve might be connected to some other part of the body, like maybe the lower leg or something, the lower leg might be affected, even though the lower leg never got treated with radiation. But again, because the nerve was affected in the radiation field, just whatever other parts of the body that nerve is serving, in that way, it could kind of be out of the original radiation field. I hope that makes sense. So anyways, these are some of the things that can happen to your muscles when you get this kind of radiation fibrosis. You can see that, it can cause like the muscles again to become very firm, very tense. And that's usually what people describe when they get these symptoms. It's just really, really tight muscles. You can lose range of motion. Again, if you have a history of breast cancer, you got radiation to your chest wall can kind of cause that breast to kind of lift up and appear kind of asymmetric with the other side. So a lot of times, when these muscles get this tight, it can be quite uncomfortable. So we divide the different kinds of radiation fibrosis effects depending on when they occur. So acute effects of radiation fibrosis will be just like immediately kind of after treatment. Early delayed effects are those that occur up to 3 months after finishing radiation treatment. And then late delayed effects are those that occur 3 months or after 3 months you've completed your treatment. So, you finish radiation treatment over 3 months ago, and then you just start to get all these symptoms now. Those are like the late delayed effects. And that's usually what I see. I usually see people, who finish their treatment like months ago or sometimes years ago. It's not uncommon that I can see somebody like, who finished their treatment like 1 year ago, 3 years ago, 5 years ago, and then all of a sudden they start feeling like tightness kind of increasing in that area. It's harder to like reach their shoulder up. It's harder to turn their neck. If somebody with a history of sarcoma, like in their leg or something, they got radiation there, then it becomes like harder to move their leg or bend their knee. So it can, this is always kind of something to think about if you received radiation in the past. And even if it finished a long time ago, again, the symptoms can manifest years later because again, that just because you finished radiation a long time ago doesn't mean that that scar tissue deposition process has necessarily stopped. And unfortunately, that can kind of continue. So again, the main symptoms that we see are muscle pain and tightness because again, those lymphatic vessels can be choked off by the scar tissue. You can also get swelling. Even though maybe you never even got any lymph nodes taken out, you could maybe still get some swelling. And then you could get nerve pain. We sometimes we call this like radiation-induced dystonia, where you basically get abnormal contraction and abnormal twitching of muscle cells. So this is something that actually, we can commonly see in the neck, in the sternocleidomastoid muscle that kind of runs right here, or again, the chest wall. So if you feel are feeling like twitching of your muscles, this could definitely be a cause. If it's localized, if you're having twitching of a bunch of different muscles, like in a bunch of different parts of your body, that's probably something else and something you'd have to talk to a neurologist about. But again, if it's localized in the field of radiation that you had before, then that could certainly be a cause. So again, most of my factors that I see is breast cancer. So we're just going to kind of focus on chest wall right now. But this is a picture of the pectoralis minor, or I'm sorry, pectoralis major muscle. So you can see that kind of connects to your sternum in the middle of the body, to your clavicle, and then it connects out to your humerus. This is like the long bone in your upper arm. So you can imagine that like when this gets tightened, because of radiation fibrosis, it'll bring like your arm forward, it'll pull your shoulder down. And same thing, this is the pectoralis minor muscle. So you can see it's connected to the ribs and then connects again to the shoulder bone. So then again, when this becomes fibrosed, it kind of shrinks down and then it'll pull your shoulder down. And when both the pec major and pec minor get pulled down, it can, pull your shoulders forward and create kind of this, what we call this upper cross posture. So, not only is it kind of uncomfortable here in the front when you can get like muscle twitching and muscle spasms in the front, but it's also causing a strain of all these muscles in the back of the neck and the back of the head and the back of the shoulders. So we really commonly see, people get pain in the front because it's too tight, and people have pain in the back because it's kind of being overstrained and overstretched. And we're all basically at our computers all the time now and all looking down at our phones. We're already adopting these postures, and you can just imagine that, when you kind of add radiation to the picture, it just compounds all of that. Okay, so what do we do about this? Fortunately, there's a lot of different options. So first I want to talk about like kind of direct physical things that we can do. Basically what I recommend to everyone is that you want to just stretch what's tight and strengthen what's being overstretched, whatever that is. So, we go back to this picture here. So, if it's the pec muscles that are tight, you want to stretch out the pectoralis muscles, and it's these back muscles and neck muscles that are kind of being stretched, the upper trapezius muscles. So we want to strengthen all those, so we can kind of develop more of an upright posture. So the important thing about this is that when you do this stretching, it has to be static, prolonged, and daily. So what static means is that you hold it. It's not like a kind of bouncing stretch or dynamic stretch. It's just you hold that position of stretch. And then prolonged means, you're not stretching for 10 seconds or even 20 seconds. I often advise people to hold the stretch for like 45 to 60 seconds. And then you have to do it really every day because again, that radiation fibrosis process, it's something that can continue even after radiation is over. So because of that, it's something you have to combat kind of daily. And depending on how many different areas are affected, we might recommend that you stretch even 2 or 3 times a day. But I've had a lot of people do this, and a lot of them do experience improvement, not necessarily complete resolution of the areas of tightness, but it can certainly help. And then, just strengthening what's being overstretched again, in the case of tight pectoralis muscles and wanting to strengthen the muscles in the back, that's going to be things like rowing type exercises, and basically squeezing your shoulder blades together and strengthening those specific muscle groups. So this is what kind of some of the stretches might look like. Again, if you have a tight anterior front of your chest wall, so this is like the doorway stretch where you just kind of stretch out your chest by stepping forward through a doorway. This is really good stretch that stretches your latissimus dorsi muscles like back here. And I recommend this to a lot of people. There's other ways to stretch your latissimus dorsi, but yeah, it's all about kind of finding whatever the right stretches for you, and you may have to kind of modify these positions a little bit, just depending on where you feel kind of the stretch the most. And then again, strengthening, we want to kind of squeeze our shoulder blades together to get kind of our rhomboids there and kind of do more rowing type exercises, again, to strengthen all these back muscles to pull us into a more appropriate and comfortable posture. There are some braces that people sometimes can wear or get to kind of help assist them into that more comfortable posture. So this is like a figure of 8 brace, and there's a lot of different styles of these kinds of braces. You can go on Amazon and get a brace like this for like, $10 or $30. For some people it helps. Definitely not everyone. For a lot of people, it does bother kind of the underarm area. But if this is something you want to try, these things are readily commercially available. Anybody can just order one of these. Okay, so that was physical kinds of treatments. So pharmacologically, what can we do? More often than not, you've probably been, if this is something you've been experienced, one of your doctors has probably prescribed you some kind of muscle relaxant. The most common ones are ribaxin, tizanidine, cyclobenzaprine, diazepam. Baclopins, I put in parentheses because that's more of an antispastic agent, but honestly, I do use it also. Sometimes for people that have muscle tightness from radiation fibrosis, and it has helped. But one thing that I'll say is that, just because one medication didn't help you doesn't mean that another won't. I had one lady that I was helping, and she had kind of tightness kind of all around after undergoing, I think she had deep flap reconstruction. She had really, really bad tightness all around, and ribaxin didn't help her at all. But then we switched her to baclofen, and 10 years of terrible, terrible tightness. And it was helped with this one medication. She was doing something else. She was also doing some vibration therapy too, but kind of both of those things together did the trick. But the idea is just because one medication didn't help you doesn't mean that another won't. It may be a good idea to rotate. Basically, all muscle relaxers can cause sedation or drowsiness. That's something to keep in mind. You can always try to lower doses to try to find the sweet spot, but something to consider. In terms of trying to actually reverse the fibrotic process, the primary medications that are given to do that is this combination right here from toxyphylline and vitamin E. Sometimes you might be offered this, and for most people it's well tolerated, but it's not uncommon to get stomach issues, which is probably the #1 reason why people can't tolerate this. It's something that I used to use a lot, and I don't use that much anymore just because I don't feel like it's that effective, but it's something that, if you're willing to try it, you could ask your medical teams about it, and they could give it to you. Just one thing that I would notice, there's multiple studies that have been done to look at the effects of pentoxyphylline and vitamin E for combating radiation fibrosis. And a lot of the literature is kind of controversial in terms of, some say that it helps, some say that it doesn't do anything. But this is one study that I like just because they used it for a really long time in people with breast cancer with superficial radiation fibrosis, more affecting their skin. So they actually found a pretty good effect that, people who use the medications, they had a 68% surface area regression. However, the mean time it took to get that improvement was 2 years. So, it's not like you start taking these medications and you'll notice a benefit next week or even in a month, but it could be several months before any benefit. And they also did note that people who stopped taking it had a rebound fibrosis. So it could be something that you're on for a long time. So again, this is not something I recommend as much these days. But if it's something you're open to or something you're interested in, it's definitely something you can talk about with your medical team. Okay, so on to some newer things that we're doing. So trigger point injections, these have been around forever. This is basically a needling technique where, somebody will inject a little bit of steroid or lidocaine or maybe sometimes saline, and they'll just go to the area of tight muscle and they'll just put the needle in and out of it to try to get it to loosen up. That can sometimes be effective. Although the effect is, temporary, maybe in the order of several weeks to months. But again, it can sometimes provide temporary relief. Botulinum toxin, not just for cosmetic purposes, Botox, as well as other brands of botulinum toxin, but it can also be helpful here, particularly if you're having muscle spasms. So, basically you just take a little bit of Botox and inject it into the tight muscles, and a lot of people get pretty good relief from this. So for example, a lot of times I will Botox those tight pectoralis muscles, and patients who have pain in their shoulders and the back of their neck will get relief from that because again, the pec isn't so tight, it's not pulling them forward anymore, so it's releasing some of the strain from some of those muscles in the back. So this is definitely something that can be helpful. The one thing that I would note is the effects of botulinum toxin are typically temporary, usually lasting only 3 months. So it may be something that likely would have to be repeated if effective. Hyperbaric oxygen is something that's also been around for a long time. However, the data and studies that were done before didn't really show that it was beneficial for radiation fibrosis, but there was a new study actually that was done, just published earlier this year in kind of a famous journal that showed that it actually might be effective. So we'll go over that shortly. The last thing I'll mention here is photobiomodulation therapy. Photobiomodulation therapy is several other names. They call it red light therapy, low-level laser therapy, cold laser therapy, but it's basically these kinds of red lights of a certain kind of spectrum that have been in very early kind of small studies been shown to decrease fibrotic changes. So this is maybe something to pay attention to in the future. Just to let you know, there's like hundreds of these kinds of devices. You just type red light device like in the Amazon, you'll get like 100 different things. Those devices, they're not like necessarily medical grade. So we don't know if the energy output from them, it's likely not what has been used in the studies that have been done. So just something to keep in mind. That said, there are some clinics, like private clinics out there that do have like prescription grade red light. And those are things that you could kind of Google search and look into. But yeah, just so you're aware, anything that you obtain like from Amazon or like another like online retailer, it's probably not it probably doesn't have enough power and intensity as what was used in any study that actually like used red light for any kind of fibrotic change. Okay, so this is on the table from that study that I was talking about that was released earlier this year for the benefits of hyperbaric oxygen therapy. This is done by Mink van der Molen. But essentially, these ratings are like, if it goes down 0, 1, 2, 3. If you have a grade 3, that's the worst. Grade 3 is the worst. 0 means like you're totally normal. So you can see, of these different severity levels for fibrosis of the breast and chest wall and axilla for patients with breast cancer who had undergone radiation treatment. After they had undergone hyperbaric oxygen treatment, so much more of them became like a stage 0, which is what we want, and much more of them for people who underwent the oxygen therapy, their severity grades basically decreased. So this is quite telling. This was a problem before for us because whenever we tried to get the insurance to authorize hyperbaric oxygen, a lot of times they would say no because the evidence didn't pan out. So lately I've been telling them about this study, and sometimes they're more inclined to say yes. It's just something to keep in mind. Hyperbaric oxygen, it is really expensive. It can be like over $10,000. In this study specifically, they went for 30 to 40 sessions, and it was like 2 hours per session. And they went like multiple times per week. They did like 30 to 40 sessions. Like it was something like over the course of like 1 to 2 months or something. So it can be quite a time commitment. And again, if it's not covered by insurance, it could be quite a monetary investment too. But if you can find some place to do it, obviously safely, they know what they're doing, and it can be covered. Again, this is something to like seriously consider and look into. As all these differences were found to be statistically significant as well. Okay, last thing is botulinum toxin. So the way botulinum toxin works, and Botox is kind of the most famous known brand of botulinum toxin, but there's a bunch of other ones. Xeomin, Dysport, Myoblock are all different brands of botulinum toxin. But essentially, the way that our muscles are able to contract and squeeze together is because the nerves basically release these neurochemicals into the junction where the nerve meets the muscle. And when these little neurotransmitters are released, it causes the muscle to contract. So what the Botox does is it essentially stops the mechanism that allows these neurotransmitters to be released. So they're never released. The muscle can never contract. So that is how Botox basically makes muscles relax. And again, this is something that we can do to really tight muscles. And a lot of times, patients can get significant relief. So another thing that I would keep in mind if you're having kind of more severe symptoms. Okay, the next complication I want to get to is cancer-related fatigue. So what is like cancer-related fatigue and how is that different from normal fatigue? So, in normal fatigue, it's really proportional to, how your level of activity. So if you've been working like 100 hours a week or, I don't know, you're like not sleeping that much, or I don't know, you just had like a newborn child, then, you're going to be really tired because, your level of activity is just much more. But normal fatigue, again, should be alleviated when you rest. Cancer-related fatigue is not like that. It doesn't matter how much you've been working. It doesn't matter how much you've been sleeping or resting. You're still just kind of going to feel tired. And it can be severe enough to the point where it kind of impairs your regular everyday activities. So what causes this kind of fatigue? It's basically always multifactorial. You have to do with, your hormones, how much pain you're in, the different kinds of medications you're on, how you're sleeping and sleep disruption. And then at the end of the day, it kind of always comes back to cytokines. Cytokines are like little chemical signals that are secreted by different cells in your body, and they basically tell cells to do other things. But some of these cytokines can, of course, cause like low-grade levels of inflammation throughout the body, and it's that kind of low-grade inflammation that can also contribute to fatigue. So the National Conference of Cancer Network, they have kind of the guidelines for treating cancer-related fatigue that they kind of update every year, and there haven't really been that many changes over the past few years, but these are all the different treatable factors that contribute to fatigue, that can contribute to fatigue. So essentially, you just want to kind of go through all these different things and optimize everything you can. And if you try to approach it from this kind of multifactorial approach, more often than not, you can get some kind of relief. So just to go through this really quickly, any side effects that you're dealing with, you want to treat those. If you're having any pain or emotional distress, you want to address that. If you're anemia, that's really easy. You just get a blood transfusion. If you have some sort of nutritional deficit in your diet or not drinking enough water, then you kind of address that. Hopefully, nobody's using alcohol or illicit substances. Medications are optimized. We'll talk about that in more detail. Obviously, you want to optimize your sleep levels, and then activity levels, kind of referring to how much physical activity and exercise you're getting. So we'll kind of go into these each in some detail. So as far as medications go, polypharmacy is defined as using 4 or more medications, and if you're being treated for cancer, it's really, really difficult to avoid. But if you're on any of these medications, these all really, really commonly cause fatigue. So any kind of narcotic, muscle relaxant medications for nerve pain, that's gabapentin, pregabalin, and Lyrica, anti-nausea medications, and antihistamines. If you're on these and you can either reduce the dose or you don't need to be and you can just get rid of it, that will help with energy levels. So that's just something we strongly recommend. So again, I'm a proponent of just getting rid of medications whenever you can if you don't need to be taking something. And if you're not sure if it's helping you, or you just don't know why you're taking it anymore, then talk to your doctor about it and just see if you can get rid of it, because that's the number one thing you can do. If you can't do that and you need it for something, maybe you can reduce the dose. Maybe you don't need to be taking a whole tablet. Maybe you can get away with like a half tablet. And then, that'll probably also reduce the side effects. Or if it's something that, you're taking in the morning and it makes you tired, maybe you can take it at night if that's okay with your medical team. So it's just the time of day that you're taking it. So these are all just really easy kind of practical things that can be done. Okay, physical activity and exercise. This is a category 1 recommendation from the National Comprehensive Cancer Network. So this just means that this is supported by very strong evidence, and there's also uniform consensus among an expert panel that doing this helps alleviate cancer-related fatigue. So this is really important. So basically what they recommend is you get 150 minutes per week of moderate intensity aerobic exercise. Moderate intensity exercise just means that your heart is beating at a certain rate. And really you can just use your work of breathing as an indicator of that. So you want to be exercising to the point where you can talk and carry out a conversation, but not sing. That's how hard you should be breathing. And if you can do that, then you're likely at a moderate intensity. And if you're doing that for 150 minutes per week, then you're meeting recommended guidelines. In addition to that, they do recommend 2 to 3 days per week of strength training targeting major muscle groups like arms, legs, back, chest. If you can do all these things, then it's been shown, again, by a lot of evidence that this can help with energy levels. And this is something I've seen time and time again. Out of all interventions that I've ever seen, exercise, for those who are able to do it. Of course, there are people in certain circumstances who can't for various reasons, but if you're able to, it's like one of the most effective treatments for multiple different things, including fatigue, that honestly I've ever seen. Okay, so in terms of non-pharmacological treatments for fatigue, there are many other things, including psychosocial interventions. It's going to be things like being in support groups, having like a diary or keeping a journal, talking to like a psychotherapist. Again, this is like a category 1 recommendation. I don't know why this works, but it does. They've done studies literally where they say, hey, talk to this therapist, and it might actually help you feel more energy. Massage has been shown to be helpful. Acupuncture has been shown to be helpful. Bright white light therapy, which kind of resets your circadian rhythm and sleep optimization. These are all things you can kind of Google to get more information about. I'm not going to go into these right now, but we'll talk about sleep optimization a little bit because I think that's very important. So difficulty sleeping is another kind of long-term complication that can occur. And it affects a lot of people with cancer. So, whenever you can get to the root of the problem, whether, you're having pain or you have like a noisy bed partner or you're feeling anxious and your mind is just racing at night, you just have to get to the root of that problem and then try to treat it. Maybe it's hot flashes. Honestly, hot flashes for a lot of people who are on aromatase inhibitors or tamoxifen. But you want to address that and then hopefully you'll be able to sleep better. And once you're sleeping better, you should have more energy as well. So whatever it is, try to get to the root of the issue. If it's, more difficult than that, then you might want to visit your sleep hygiene. Like you take a lot of daytime naps, or you're drinking like coffee or caffeine right before bed. Are you going to bed with your phone? I mean, basically all of us do that now, but none of us should. It's really bad sleep hygiene. Or maybe there's a lot of ambient light, or ambient sound, that's kind of preventing sleep. These are all things that you kind of want to address to kind of optimize your ability to sleep. And kind of one of the ways that you can go from bad sleep hygiene to a good sleep hygiene habit where you are doing stress reducing activities and being in a dark and quiet room is through cognitive based therapy or cognitive behavioral therapy. We call the CBT or CBT for insomnia. This is like one of the #1 recommended things for anybody who's struggling with insomnia. And there are multiple different programs out there now. This is, if you're like a person who's had difficulty sleeping like most of their life, this is like 100% something you should pursue. And there's a lot of self-directed programs out there now. Go to Sleep is a program developed by Cleveland Clinic, famous hospital in the Midwest. And their program, last I checked, it was $40. It probably still is. The only thing I can say about cognitive behavioral therapy is it requires a lot of effort. Like you have to keep like a sleep diary, you have to like track how much like you're waking up at night. You have to, they'll tell you to do a lot of things. You have to like read something like to learn about sleep and sleep behavior like every day. So it takes quite a bit of effort. But again, the research supporting this as a therapeutic intervention is quite substantial. So again, if you're someone who struggles with sleeping like a lot of their life, this is something you should check out. I most of the time recommend Go to Sleep to people. CBT I coach was developed by the Department of Defense in conjunction with Stanford University. There's also a lot of research supporting this one. This one's free. In my opinion, the user interface, it's not as easy to use, but it's something you could mess around with. Sleepio, I think was developed in Europe. I haven't used it myself, but it has a lot of research behind it as well. But any of these you could check out if CBTI is something you're interested in. Okay, finally, medications. There's tons of different kinds of medications and sleep aids out there. Melatonin, honestly, a lot of people take it, and if you want to try it, that's totally, well, it's not totally fine. It's gotten more of a bad rap recently because of purity issues and dosing. They've kind of, certain brands of melatonin have been accused of having improper doses or like the dosing is not what's labeled. But anyways, let's say you're getting like the proper dose from a reputable company. You could try it, but again, the evidence supporting it is not the best unless you're taking it for jet lag or if you're like working like nights or something. All these other medications are stuff that is commonly used. There's antidepressant medications, benzodiazepines and their derivatives. That's stuff like Ambien, Lunesta, or Ativan. And then there's this kind of newer class of medication called orexin receptor antagonists. Some examples are balsartan and Qvivic. These medications I've used a handful of times now, and they can be helpful. They are like newer and kind of more expensive. So sometimes insurance barriers are an issue. But usually for most people, one of these things will kind of help. It's not great to have to take a medication for sleeping just because some of these things are habit forming, but if you really need something, then something you can talk to your medical team about. Okay, next complication is chemotherapy-induced peripheral neuropathy. I'm going to try to speed up a little bit here because I think I'm short on time. So the common symptoms of chemotherapy neuropathy are basically symptoms of numbness, tingling, and sometimes burning and sharp or achy pains in the hands and the feet, most often starting in the fingers and the toes. So we divide into positive symptoms. Those are new sensations you get that you haven't had before: burning, tingling, sharp pains. And then there's negative symptoms. Those are things that you lose. So you lose your sense of sensation, which is numbness, where you could lose your balance or lose motor control, which is your strength. There's a lot of different kinds of chemotherapy that can cause neuropathy. These are a lot of the most common ones, and the rates at which they can cause neuropathy are quite high. So, for example, a lot of patients who have gastrointestinal cancers, like colon cancer, they will receive oxaliplatin, and you can see the incidence. If you get oxaliplatin, there's like an 85 to 95% chance that you'll get neuropathy. So depending on the kind of treatment you get, it's just to say that this is a really common side effect. In most people, these symptoms will get better typically within 1 to 3 months. For some people, it may take longer, like a year and a half. If your symptoms are persisting after that, then it is very possible that the symptoms will continue for years. But that doesn't mean it can't get better. It just might take a longer period of time. One thing that I want to quickly address is the coasting phenomenon, also called the coasting effect. So there are certain kinds of chemotherapy, those that are based off platinum drugs, as well as vinca alkaloids like vincristine and vinblastine, which are more commonly used in patients with like leukemia or lymphoma. But these agents can exhibit the coasting phenomenon, where after you stop chemotherapy, symptoms of neuropathy can start or worsen. So we see that demonstrated in this graph here. Like all the shaded area is after chemotherapy was stopped, and you can see that even after chemotherapy was stopped, a lot of these patients like sensory symptoms worsened over time, as demonstrated by this decreasing line. So it's something, again, to talk to your medical teams about, but just if your symptoms, if you're receiving something like cisplatin, and your symptoms start after you finish chemotherapy, it could still have been from the cisplatin. Okay, in terms of prevention, if you Google preventing chemotherapy neuropathy, there's going to be like 100 different things that pop up. A lot of them are going to be supplements. There's a lot of things that are touted to prevent chemotherapy neuropathy. None of this has been proven to really prevent it. And this is ASCO is the American Society of Clinical Oncology. It's like the big cancer doctor organization in the United States. These are all cancer organizations in Europe. And basically, they all state that there's not enough evidence to give a positive recommendation for anything in preventing chemotherapy neuropathy. That said, something that a lot of people do, and I'm sure many of you have heard about, is preventative cryotherapy. That's where you get like these frozen gloves and like frozen booties that you kind of wear while on chemotherapy. There are some studies out there that show that this is effective, but there's other studies that show that it's not. So in my mind, this is kind of still up in the air. But if your infusion center is okay with it and your oncologist is okay with it, something you can try. Again, this is all stuff that you can buy from online retailers. But it's just difficult usually because it's putting something frozen like on your hands and feet and keeping it on during like the entire infusion. So it's not possible, or it's not easy for everyone to do. But if it's something you're interested in and your medical team's okay with it, again, it's something you could certainly look into. Okay, if you do develop chemotherapy neuropathy, you develop some of these positive symptoms of pains or burning or aching, then there are things that you can try. So there's a bunch of different oral medications that are listed here. There are a bunch of different topical medications that are listed here. I'm going to briefly talk about capsaicin because this is something that we've been using in my clinic that we're finding is increasingly effective. Again, these supplements, not great evidence that it does anything, but a lot of people do take alpha-lipoic acid and B vitamins. Some people feel like it does something. And then there are these kind of alternative therapies, scrambler therapies, like a type of electrical stimulation therapy. and then kind of like these different specialized socks that are out there. But really, I want to talk about capsaicin. So what is capsaicin? Capsaicin is derived from the plant genus capsicum, which are spicy chili peppers. So capsaicin is literally the compound in chili peppers that makes the chili peppers spicy. So that burning sensation that you get in your mouth when you eat something spicy, that's from capsaicin. So, what they've done is, they can concentrate it. And there is capsaicin that's available over the counter, but I believe the highest strength is 0.1%. The prescription grade capsaicin is 8%. So it's like 300 times more potent than what you can get over the counter. And essentially the way that it works is it kind of binds to the nerve cell. And it basically makes the nerve cell inoperant to the point where it can no longer transmit pain signals. So basically causes desensitization. Now, it doesn't affect all the nerves, so it's not going to make you completely numb. It really only affects the nerve fibers that transmit pain signals, and it desensitizes those pain signals. So what we do is it's something that has to be done within a medical provider's office, but it's like this patch. Usually most people get neuropathy on their feet. So they'll like kind of slather your foot in lidocaine to make it numb before the painful burning patch goes on, and then they'll apply the patch. The patch will usually stay on for a period of 30 or 60 minutes. It's really well tolerated. We've been doing this in our office like a ton over the past year. A lot of chemotherapy and neuropathy, and we're finding a lot of evidence that it's pretty effective. So if this is something you've been struggling with and you've tried other things and they're not working, ask your doctors about this patch. It's something that could potentially be helpful for you. And just to be clear, the brand name for this patch is called Qutenza. But again, it's just a capsaicin patch, and the brand name is Qutenza, Qutenza. And the last thing regarding neuropathy is, again, if you is affecting your senses in your foot or the strength in your foot, it can obviously affect your balance. So it's important to consider physical therapy or like assisted device like a cane if you're having difficulties with balance. It is really common for people with more severe neuropathy. But if you 1 to 2 months of physical therapy, within like that short period of time, you can actually get a significant improvement in your balance. For people who have a lot of neuropathy from the chemotherapy affecting their hands, and they have trouble doing things like typing and texting, or writing, occupational therapy can also sometimes be helpful. So you can talk to your medical teams about getting a hand therapy referral. Okay, moving on to cancer-related cognitive impairment or chemobrain. So chemobrain, or chemofog is basically something that really commonly happens to anybody who has cancer who they may not have even gotten chemotherapy. So that's why the term we use is cancer-related cognitive impairment, because really we think it's caused by, again, these cytokines that are kind of causing a low-grade inflammation throughout the body, but it's affecting the brain. And when that happens, you can get symptoms of memory lapses, difficulty focusing. Word finding issues is probably the #1 thing. It's like you're trying to think of a movie or the name of a person or a book that you read, and it's just not coming to you. Slower processing speeds, and trouble with details are really all really common symptoms of cancer-related cognitive impairment. It's extraordinarily common for people who are experiencing treatment, and a lot of people wish that they had some kind of support when they're feeling these kinds of symptoms. And again, it really has to do with inflammation. You have the tumor cells and the immune cells that are creating this inflammatory environment that releases these cytokines. And then again, that affects the brain, and it can lead again to fatigue, but also to cognitive impairment. So some of the treatment strategies are things like mindfulness, trying to regulate your thoughts and your emotions, lifestyle modifications that we're kind of talking about, fatigue, as well as different cognitive training strategies. So one thing that we offer at Cedars-Sinai, and there's not that many programs out there for dealing with this kind of thing, but at Cedars-Sinai, my colleague, the director of wellness, resilience, and survivorship at Cedars is Dr. Rosh Asher. And he's developed this program with Dr. Jeffrey Wertheimer. It's called Emerging from the Haze. This is basically a 10-week psychoeducational program that talks about different lifestyle modification. So it's optimizing things like sleep, nutrition, stress reduction, and physical activity. And they've done studies on this program, and it's basically shown that people who go through it perceive less cognitive impairment. So lower scores is kind of worsen cognitive impairment. Higher scores is better. And again, you can see that the intervention, that people who went through the program, they had just higher trajectories. And they felt like, you know, their cognition was better after going through this class. So it's something to consider. Okay, finally, the last thing I want to talk about is chronic post-surgical pain. This is also sometimes called chronic post-operative pain, or kind of persistent post-surgical pain. Yeah, if you or someone you know has undergone surgery, this is certainly something that can occur. So typically, you know, you have your surgery, and then after surgery, you're going to wake up in pain, and that's normal. And then, you know, a few weeks after surgery, you know, in most people, we expect their pain to decrease or resolve entirely. But in some people, it will just continue or worsen. And maybe in a couple months later, the pain's kind of still there. But in most people, it really should have resolved. Now, if you reach kind of that 3-month mark, that's when we kind of start calling chronic pain. There's no consensus definition of when chronic pain begins, but most people will say either 3 months, 6 months, or 9 months, or 12 months. But, you know, if you have had pain going on for 3 months or longer after your surgery, it is chronic at that point. And it may be time to start considering some different kinds of options for treating it. So there's a lot of different kinds of surgeries that can cause chronic pain, like amputations, like at the shoulder level, at the knee level, or at the ankle. Yeah, some people can get phantom pain. If you underwent a thoracotomy or a lobectomy, like lung cancer, if you've undergone a lumpectomy or mastectomy or some kind of reconstruction surgery, for people with kind of pelvic cancers, if you get like prostatectomies for low anterior resections, these are all different kinds of surgery that may result in chronic pain, but it's not limited to these kinds of surgeries. Some people have chronic pain after undergoing hernia repairs. So really quickly, I want to talk about different types of pain. So there's nociceptive pain, neuropathic pain, and nociplastic pain. These are the kind of 3 different kinds of pain that there are. So nociceptive pain is the typical pain that you get when you activate a pain receptor. The other name for a pain receptor is a nociceptor. So let's say you cut your hand. That's going to like activate a nociceptor or a pain receptor in your hand. It's going to trigger the pain signals to go up your nerves and then to your spinal cord. It's going to go up your spinal cord to your brain, and then your brain is going to, you know, make you feel the sensation of pain. In neuropathic pain, you're not activating pain receptors. You're just kind of triggering the nerve itself. And again, you're sending those pain signals up the nerve to the spinal cord, up the spinal cord to the brain. You feel pain. Now, nociplastic pain, this third one down here, is different. Nociplastic pain is different in the way that pain is modulated. So really, we think about nociplastic pain as occurring when there's an abnormal way in which the nervous system is processing the pain signal. So really, this is occurring at the level of the spinal cord and the brain. And you can think about it as an amplifier. So when you have nociplastic pain, it's as if your pain is hooked up to an amplifier and the dial of the pain is being increased. So that's nociplastic pain. And it's through these kinds of mechanisms that we believe to a degree, at least somewhat, that chronic pain, including after surgery, may occur. But the truth is we don't understand it entirely. So, you know, if chronic pain is something you're dealing with, there's a lot of different therapies that are out there, including medications, different kinds of injections and nerve blocks, topical medications, all manner of other kinds of modalities. And I'm not going to talk about these, but I can send out my slides later to anyone who's interested. Yeah, these are, you know, if chronic pain, post-surgical pain is something you're dealing with, while elimination of the pain entirely might not be completely possible, like getting it down to a level where it's tolerable and you can kind of do the things you want to in life, that I've definitely seen before, and I think that's possible for many, many people. Yeah, please look into these different kinds of therapies if that's something you're dealing with. Again, these are a bunch of different topicals that I regularly recommend. Again, these are different recommended medications if nerve pain is something you're dealing with, but I'm gonna kind of skip the end here, so we can go through some of these questions. But again, if you're having uncontrolled pain, then it may be helpful to be a specialist. And the best people to see would be a supportive care medicine or palliative care physician, a pain management physician, an interventional pain management physician, or somebody in my specialty, physical medicine rehabilitation. And sometimes you might need to see multiple of these doctors. Yeah, if it's something you're struggling with, yeah, there's definitely help out there. Okay, so this is my email address in case I'm not able to get to any or all the questions, or if you just want to email me your question directly, please feel free to do that. But otherwise, that's all I've got. So I'll open up this chat and see what we've got here. Okay, let's see. Question: are there any new treatments to address radiation fibrosis for nerve pain, scar tissue, tightness, mobility issues? So the newest treatments that there's nothing that's like really commonly used, but I would say things that we've been using more in our clinics are red light therapy, so that photobiomodulation therapy, and hyperbaric oxygen. So I would say those two things specifically. But again, it depends. I've seen aquatic therapy work really well for a couple of people who had really, really bad radiation fibrosis, where they kind of get into a heated pool and do exercises in the heated pool. But yeah, I'm going to say those two things primarily, photobiomodulation and hyperbaric oxygen. Okay, next question. Does Cedars-Sinai offer these treatments? Is this mainstream or not so much? Okay, that question was asked at 3:25. I think I was still talking about radiation fibrosis then. So yeah, it depends. Like some of the like all the muscle relaxants, that's going to be mainstream. You can get that from anywhere. Things like stretching, that's also mainstream. You can get that anywhere. Stuff like Botox, that's going to be a little less mainstream. You'd have to see a specific provider, usually a neurologist or a physical medicine rehabilitation doctor, or like a pain management specialist. Cedars, will offer most of these things, but we don't have hyperbaric oxygen. We don't currently have the red light thing working, but we're working on getting our own. So probably like within the next year, we'll have that. But yeah, some of these other things, like the more new investigational stuff is, yeah, that's not going to be mainstream, and you're going to have to do a little bit more digging to find something. Will we be getting a copy of this PowerPoint? Yes. What about magnesium for sleep? Yes, that's a great question. Magnesium can be helpful for a lot of people. I think the most commonly used one over the counter is called Calm. The only thing that I'll say about magnesium is depending on the kind of magnesium you get, it could be effective for sleeping, or it could cause like loose stools and diarrhea. Because magnesium is sometimes given for that purpose. So like, for example, magnesium citrate or magnesium oxide, those could be used as like diuretics where they like induce like a bowel movement, whereas the best supposedly like one of the best absorbed magnesiums is like magnesium glycinate, magnesium threonate, I believe, is also supposed to be well absorbed, and magnesium chloride. So it really depends on that second word after magnesium and the kind of magnesium it is. Can we obtain more info on emerging from the haze? I would encourage you to Google it. You just Google Cedars-Sinai emerging from the haze. There's a little bit more information on the Cedars-Sinai website, but you'll also be able to find out about the studies that have been done regarding it. But if it's something you're interested in, send me an email, and we could we could see if we could even get you in on like the next classes. Okay, I think that's all the questions that were in the chat. Does anybody else have any other questions, or you can feel free to unmute yourself or just post in the chat as well.
Thank you so much, Dr. Chang. That was really a wealth of information. Just a reminder that this workshop has been recorded and Dr. Chang has agreed to share his slides. So if you would like to review this in the future, or when you're ready for, to address this, please email me. I put my email into the chat and I will get it to you as soon as I can. Like Dr. Chang mentioned, we do have a couple more minutes. If anyone does have any questions, you can put it into the chat and you can read out loud, or you can also unmute yourself and ask your question. Wonderful. Well, thank you so much, Dr. Chang. This is really wonderful workshop and workshop topics. Thank you for your time and for your expertise on this matter.
Thanks so much for having me, and thanks so much everyone for joining.